We have a wonderful panel today, and hopefully you've all picked up the bios, because I will not go and read through it. If not, take the bios on the way out, or our distinguished panel will briefly talk about their past. But I'm going to start off with David Cloud of the Vera Institute, and next to him is obviously Elizabeth Glazer, who just finished a bite. And then finally, Anne-Marie Lewison of Cases. And what they're going to do, the way that this usually works, is very informal. We will start off with about 5 or 10 minute presentation or overview, where each of the panelists will talk about the subject matter. And then afterwards, I will ask a couple of questions to get the ball rolling. And then finally, we'll take questions from you in the audience. And then at that time, we will try, and we usually like to stop promptly at 1:30, because we all know that everyone here has a day job. So with that, I'm going to try and keep what I have to say short. And I want to start with David. Why don't you lead it off?
Sure. So can everyone hear me okay? I'm kind of a soft speaker sometimes, but so thanks for having me.
Move
The microphone might help with that. So for those of you not familiar with Vera, Vera is a think tank here in New York City. We do a lot of work in criminal justice reform. I work for the Substance Use and Mental Health Program. We do kind of a range of research, policy work, kind of at the intersection of health and justice. So since coming to Vera, I've been trying to get our organization to think more broadly about kind of beyond the substance use and mental health world, and to kind of the deeper public health implications of kind of unprecedented growth in the correctional populations. So this November, we launched an initiative we're calling Justice Reform for Healthy Communities. You may have seen the report that came out. It is called On Life Support, Public Health in the Age of Mass Incarceration. So the purpose of this first report was really just to put kind of our stake in the ground and say this is an area that Vera is going to continue to focus on in the future. We see it as a pressing one very important one. So what the first report set out to do is kind of frame this issue. So we hear a lot about the U.S. leads the world in incarceration. We hear these statistics over and over. So we really kind of wanted to change the conversation and look at this strictly through the lens of public health. So we wanted to go through, scour the academic literature, scour the gray literature, and look and see first who's behind bars. So we know that the disparities behind bars are grave, disproportionate representation among people with mental illness, infectious disease, chronic disease, prisoners who are aging. All of those issues are kind of manifest in correctional facilities. So we wanted to shine a light on that, which is a population that is detached from the big epidemiological surveys that are used to define how we define population health, how we define the burden of disease in society. That population is often neglected. So we wanted to kind of bring that into the forefront. The second kind of component we wanted to do was look at and discuss how the conditions of confinement impact population health. So, you read about litigation, you read about advocacy work, you hear all the time that jails are crowded, they're violent, too many people are kept in solitary confinement, the quality of correctional health care is kind of not so great all the time, and long story short, these conditions have impacts on people's lives, on their health, and they don't stay there forever. They churn and they cycle and they go into communities, they go into back through correctional facilities. So we just wanted to communicate that those conditions of confinement do have a public health impact. And then where we kind of really wanted to enter into the public health language and the public health world is to look at this through the lens of social determinants of health. It's a helpful framework for looking at a lot of kind of issues, especially ones that have to do with economics and social policy and kind of bigger picture things. But we know that, what's often termed the collateral consequences of mass incarceration are real, they're significant, and they're intergenerational. So this means that spending time in prison, having a criminal record, the stigma alone can often impede things like getting a job, family structures, feeding into the number of children who are in foster care, kind of these inter-system implications of this 40-year-long process. So we wanted to hone in on those, and the report kind of summarizes what we know from a lot of different kind of fields, a lot of sociology. that looks at kind of the economic impact and the social impact of these other systems. So setting it up in that way, we talk about the direct impact on people, the conditions of confinement, and the kind of intergenerational spend that it has, the implications for other systems. But we also wanted to, just not be completely stark about everything. And we see this, and I think, there's a lot of evidence if you're paying attention to the media that now's kind of a ripe moment to move reform. And it's not just places like, New York, where we have this, ambitious task force and things like that. It's, there's a bipartisan kind of energy behind it. I mean, the Koch brothers are talking about this, and alongside the ACLU, George Soros, Right on Crime. I mean, there's kind of this weird energy that looks so different than what we saw kind of at the beginning of mass incarceration, which is a very different political context. So we want to call action to that. And then the other component we want to talk, or that we address head on, is the implications for health reform on criminal justice reform. So you've probably heard some about, more jurisdictions doing more to enroll people in the correctional system into Medicaid, connecting them with different types of service delivery models. And Anne-Marie's doing a lot of this work in cases, and other folks in the state. But the Affordable Care Act has big implications. Why? Well, really in states that have historically not extended benefits to childless adults, so people about 133% of the federal poverty level, Medicaid eligibility is now income-based in all of those places. We're bringing people onto the rolls that have never had access before. Their mothers didn't have access, their grandparents didn't have access. And this is going to be kind of one of the historic biggest expansions of health coverage for folks. A lot of those folks come into the justice system often because they don't have access to essential healthcare services in the community, specifically mental health and criminal justice. So we wanted to, call attention that now is a really important time for champions of reducing correctional populations, improving programming at different intercepts along the system, whether it's diverting people from coming in the first place or helping them on their way out. We want to help kind of a new coalition of stakeholders become involved in conversations about mass incarceration. So, we attend these Manhattan Diversion Forum meetings. It's been fascinating to have folks from the managed care companies there, the insurance field, thinking about these issues of over-incarceration. So you bring, the field of medicine, you bring the insurance companies, you bring these new stakeholders to the table to talk about these issues, and you change the dynamics of the conversation. And, some people think that in states that aren't expanding Medicaid, one of the biggest champions for them could be, folks who run the big metropolitan jails, who see this population come in and out each day. There's, whether we're talking about human rights or money, there's, a compelling argument that these folks need health insurance. So this initiative for us is really a first step. We're going to take a stab at addressing some other issues. We're going to write some more issue briefs, some more papers, do some convenings. And for anyone in the room that's interested, please don't hesitate to reach out to us. We're all about good ideas and making good ideas happen. So with that, I think I'll pass on to Liz.
Great. So I'm Liz Glazer. I'm the director of the Mayor's Office of Criminal Justice. I sometimes get that title wrong, so I always have to think. So I guess where I would start is, in New York State and in New York City in particular, we've seen these just enormous and miraculous drops in crime. You think about the murder rate that in 1993 was north of 2,200, and last year was, about 320. That's an extraordinary thing. I looked the other day at what the violent crime rate was in the Upper East Side, the 19th precinct, and in 1994, and what it is in Brownsville, one of our most troubled communities as far as violence goes today. And they're about the same, 1994, 2014, those two neighborhoods. And so this is sort of quite a miraculous thing when you think about it. But when you look at sort of what's happened to the crime rate, there are sort of two very stubborn problems that remain. One is domestic violence. When you look at sort of what the big categories are of murders, for example, that still remain. You know, if you were to look at gang-related, DV, other things, DV is one of sort of the big chunks. 40% of our assaults are domestic violence assaults. And the other piece that is stubborn is the population of people who suffer from mental health issues or behavioral health issues, because as you know better than I do, you know, often sort of co-occurring disorders. And so when you read the coverage of you know, how the jails and prisons are becoming warehouses for the mentally ill, yes, absolutely. Bigger percentage of the populations are suffer from mental illness, but as sort of an absolute number, it's more or less remained the same. It's just that our populations have gone down, but the number is there. And so to me, sort of what that says is we figured out how to control crime. That's sort of this miraculous thing that we've done. You know, crime used to be this thing that was just washed over you, and you kind of checked later to see whether it was up or down. And now we actually think, and we are able to adjust it. But for certain populations, we don't know what to do, and we don't seem to have options. And we are sort of very atomized. And to me, kind of what the you know, what it's about kind of systemically is first getting better at recognizing what's in front of us, at recognizing who are the people who, at least in the criminal justice system, which is sort of what I look at, who are coming through. Second, finding out what actually works. Two big things that are sort of hard to figure out. And then the third big thing is figuring out how to match the right people to the right program at the right time. And those sort of sound very simple, but are really, really hard. And it's hard because the system is complicated. There are both a lot of points along the way, you know, before arrest, jail, going back into the neighborhood, and then sadly, sort of that whole ecosystem repeats. It's complex at every single intercept point, you know, as David was sort of saying. Yes, that you know, that the group that Joel and everybody else is part of has like a gazillion people from a gazillion different, you know, places, which is great, but it sort of indicates sort of the dimensions of this issue. This summer, the mayor convened a task force that was really sort of the galvanizing incident was, people may remember that there was a homeless, mentally ill veteran named James Murdow, who, sadly in the parlance of the corrections department, baked to death in his cell and died. And Murdow had been found in a housing authority stairwell by police who were on patrol. They arrested him for trespassing. He went before, you know, was written up by the DA's office. He went before the judge. The judge looks at his rap sheet. The rap sheet has lots and lots of warrants for very minor offenses. The guy is homeless, mentally ill, you know. He gets sent to Rikers and ultimately dies. And sort of for the mayor, I think that story was a sort of a trope for everything that goes wrong, right? You know, so when the police find a James Murdow, do they know who they're seeing in front of them? If they understand who they're seeing in front of them, do they have an option other than hospitalization or arrest? When James Murdow appears before the judge and the judge sees his rap sheet, the judge says, well, I can't take a chance that this guy isn't going to come back because he hasn't come back 25 times before. But what are the reasons for that? And so the judge has no option and says, and I'm painting this in, I can see Joel like raising his eyebrow. I'm painting this in cartoon terms, but I'm more or less hitting the high points here. And so Murdow ends up at Rikers, and you know, while sort of huge efforts and huge investments now in trying to improve Rikers, there are problems there. And had Murdow survived and been released into the neighborhood, then what? Would there have been the kinds of services to connect him? Would he have been connected to a health home or signed up to Medicaid? Would he have been in supportive housing? So all of these sort of were issues that the task force did at warp speed. So the notion was 100 days, we will get the greatest experts at every system point together to look at this. Partly we were able to do it because so much great work is already happening on the ground that it really just sort of needed to be hot-wired together. Enormous enthusiasm because I think people were glad to be able to sort of have a panoramic view. And by the way, Scott and Andre are in the audience, and so thank you to Langelot for having funded the work. So, you know, almost 400 people were involved in this task force. We had working groups at sort of every system point. We went to every borough. We mapped the entire system from end to end. And Trish Morrison, who's in the audience, is now sort of leading the charge of the action that's going forward. And so I'm just going to sort of give you a couple of the kind of tips of the waves about what happened and what the onward work is. And then I'm going to just give a little pitch at the end for another related piece that I think is really interesting. I'm hoping somebody might ask a question about. So the notion was we would look at every system point, we would look at how it all fit together, where we could go systemic, we would do systemic solutions. Where we didn't quite know, we would do pilots, but my boss at least hates pilots, and so the notion is let's sort of keep intensive focus on the pilots and go to scale if they work, and if they don't work, correct and figure out what does. So at arrest, sort of at that point, for arrest, the notion is let's make sure that cops are trained to understand who they're seeing in front of them. And let's give them options of a place to go that's not jail or hospitalization. So two pilots are going to start, one in the late summer and one the following year, that will do exactly that. And part of the reason why that's a pilot and not sort of let's just go to scale and have, you know, crisis intervention teams everywhere is that we actually don't know how many contacts police and other first responders have on the street every year with the mentally ill. We know about emotionally disturbed people, but we don't know what they're seeing and what they need. At arrest, sort of the systemic solution here is to, and it's for the mentally ill, but beyond the mentally ill, is to begin to take risk seriously. You know, not all mentally ill people are dangerous, not all of them are violent. There are ways, and that's true of sort of the defendant population generally, and jail is not always the right solution. So let's have an instrument that can actually inform judges, defense lawyers, prosecutors about what works for whom. Let's ensure that we have other options. So we quadrupled the number of slots available for judges, it's called supervised release slots, for judges to say, you know, instead of putting you in, I'm going to put you in supervision. At Rikers, an enormous infusion of money and effort. The budget that was just announced earlier this week, I think Rikers has the single largest chunk of dough for the second period in a row in the city budget, going to programming, to culture change, to reentry, and a whole array of other things. Big focus on ensuring that those contacts and connections that people coming out of jail are connected, not just to Medicaid, but to health homes and to other benefits. And then in the neighborhoods, we are funding just about 300 slots of supported housing sort of around this fuse model, which has shown such, when this experiment sort of happened before in New York, showed such huge reductions for the mentally ill, criminally justice involved homeless population, reductions in hospitalization, homeless shelter stays, and jail stays. And you may think, well, 300 isn't that much, and it probably isn't, but I'll give you just one little factoid before I end, which is there was a really fascinating study that was done by the Department of Health very recently, which looked at who the high flyers are in the jail system in New York City. So 400 people who had more than 18 arrests apiece, who accounted for about 10,000 jail days. So these are our guys, and they are the mentally ill, they are the homeless, they are obviously the criminal justice involved. So these are guys, serving that life sentence a few days at a time. And so those 400 guys, if we can sort of figure out how to intervene in their lives in a significant way, and maybe supportive housing is one piece of it, then the James Murdaughs of the world, that trajectory gets intercepted. So I guess sort of the last thing I just wanted to say is, when we talk about these kinds of issues, the mentally ill, domestic violence, criminal justice, and we think about sort of these knotty problems, the one sort of piece of hope that always sort of strikes me about it is that maybe it's hope, maybe it's depressing, I don't know, this is probably like a Rorschach test, so you be the judge. But distress is concentrated, right? Brownsville has been Brownsville forever. Montgomery has been Montgomery forever. I recently looked at the top 10 top high shooting neighborhoods in '94 and now. 8 out of 10 of them are the same. The shootings are way, way down, but it's sort of the power of place is depressingly constant, right? And it's not just concentrated in place, it's concentrated in people also. It's not that every single person in a poor neighborhood is, involved in the criminal justice system or is dropping out of school. It's a small number of folks. That's the hopeful part. And it's not just that it's a criminal justice issue or a health issue or a vacant building issue or an employment issue. These are knots of problems, and we spend a gazillion dollars on sort of essentially 20 square blocks in the city of New York. And we spend it from many, many, many different agencies, not just here, but on the state level, the federal level, in sort of all engaged in this enormous game of parallel play, right? So one thing that we're now doing, and my comrade Paul Francis from the state is here also, when we started in the state, and are now doing in New York City, is to try and focus on those neighborhoods and to identify the kinds of resources that are going into those neighborhoods and to figure out how do we hotwire, what is the door in? The door in could be asthma, the door in could be anything. It doesn't have to be criminal justice, but once we start to kind of pull on that thread, I think we unravel the sleeve together. Yes, thank you. Well, probably you didn't hear a word I said. I totally did.
Good afternoon. I'm going to share my 5 minutes with Dr. Janet Taylor, who's at the front. So she's going to actually talk about a person that she's serving in our clinic. So my name is Anne-Marie Loizon, and I'm the Director of Adult Behavioral Health Programs at CASES. And CASES is a provider like other sort of sister agencies. We have a history of over 40 years of providing alternatives to incarceration for youth and adults, and people who are living with serious mental illness. And sort of 15 years ago, I came to CASES, having immigrated to the US and working in the state hospital to start the Nathaniel Project, which was one of the first alternatives to incarceration programs in New York City for people with serious mental illness convicted of felony crimes. And last week I had the pleasure to be in DC with Dr. Jennifer Scheme, who's done a lot of work on how to respond to people that sort of are high risk and have serious mental illness. And I encourage people to read Jennifer Scheme's work, because I think that the recipe for us is to be brave, as Liz has described, as we think about how to intervene. So I'm going to use cases as a very brief case study to highlight who are the people that are involved in the justice system, and to remind myself of who the people are. I went back to a report that was written by Heather Barr, who had advocated many years ago for alternatives to incarceration agencies to start providing services to people with serious mental illness. And so Heather was a mental health worker, community worker in a shelter before she went to law school, and then was a Soros Fellow. And what she found when she wrote her report called, and I have to read it, Prisons and Jails, Hospitals of Last Resort, the Need for Diversion and Discharge Planning for Incarcerated People with Mental Illness and Criminal Justice System. So she wrote this report in 1999 after she did a scan of New York City. And so everything that's in this report is as Heather had said 16 years ago. And so I just want to remind us of that as we all focus on being brave, because there was a lot of this information was out there. But a couple of things that Heather did is she raised the question, I think as Liz has done, of who are the people with mental illness who are involved in the criminal justice system. I think that that is just a very important question, and then the question of what do they need. And so if we think about the population, I think that trying to suggest that they are a homogeneous group is just not helpful, that it's a very specific population. And so in Heather's report, she says, not surprisingly, people with mental illness in the city's jails are marginalized in many ways. They are overwhelmingly people of color, 50% of African American and 35% Latino. And they are disproportionately female. Only 10% of the city jail population then were women, but 17% of the folks receiving mental health services were women. And so for me, in thinking around how we can describe cases, studies, and what we need, I think that if we take public health, that we should think about health disparity as a good framework when we think about people who are involved in the criminal justice system that need mental health services. So today, we're just going to sort of concentrate on talking about a clinic that, an outpatient mental health clinic that cases have started. It's called the Nathaniel Clinic after the Nathaniel Project. And Nathaniel Preston was a real person who was on Rikers Island for over 2 years, and was someone who had been in hospitals for many years, in and out of hospitals, and only ever, in his experience, he was an African-American man in his 1930s when Heather had met him, he only ever received mental health treatment services in jail. And so that's really an important phenomenon as we think about who are the people who are in our jails. As I was looking at the landscape of folks, the sort of looking at people with mental illness in the criminal justice system, and there was a report written when I was 10 in 1976 by two psychiatrists who were working in a county jail, and they wrote this report in the American Journal of Psychiatry, and they just found an overrepresentation of people with serious mental illness. And so I think that, as Liz had described, the people have always been there. I think we've become more conscious of them, and under Liz's leadership, I think we are being more systematic on what we are sort of doing. So why did we, at Cases, open a clinic, which is a really torturous fiscal proposition, as my boss is sitting in the front row, and has got more grey hairs in the last year as we've been like, let's open a clinic. And we opened a clinic because for many years, for over 15 years, we've been working with people with serious mental illness who we have got out of jail, who are collaborators and our partners, who are the prosecutors, who are the judges, who are the defense attorneys, have given us the trusted cases to serve that person in the community. And some of these people have done very serious crimes and people have been victimized, but the court system, our criminal justice partners, have given us that person and said, you know, you said you can help them, go help them. And our framework was to link them to services. And what we found at the moment when the people that we wanted to serve wanted to receive treatment, wanted to get access to treatment, that the receiving entities were not opening their doors and had really sophisticated mechanisms in how they kept our clients out. So that's why we started the clinic. I remember I used to do this work myself before I became an administrator. I remember folks saying to me, your client needs a high level of care. And the program was the highest level of care in terms of the model that there is, you know, and so these are issues that Liz and Trish are going to have to sort of work out around how we get the community social services to partner with criminal justice. And I think that that's the important thing. What we know about diversion, when it works in reentry, when it works for people with mental illness, is that there's really close collaboration between the criminal justice system and the mental health system, or the substance abuse system, or the behavioral health system. So how do we create those partnerships that are really strong, and the folks who are psychiatrists like Dr. Taylor think in her framework as she's working with someone who's involved in the criminal justice system, she's thinking, I have to reduce the symptoms of depression, but also how am I going to help that person not steal again, you know, and sort of return to the jail. So that's just a sort of important framework of, we started a clinic. We are focusing on folks who are involved in the criminal justice system. Some of the lessons that we have learned is that people do want services, you know, and so you've got to make them accessible. That if they, we had a great story yesterday of a man who returned from a federal prison where he had been since 2009 to New York City. And so where does he go for housing when you return after being incarcerated? You go to the Bellevue Men's Shelter. And so he was referred by a prison in North Carolina, and it just so happened when the social worker in the prison was trying to find services in New York City, he had been once trained by a really great guy who works for the county mental health in Westchester. So he called up Richard and said, who should I call in New York City to get my client services? And they referred him to us, and the individual was released, and he came to the clinic, and he saw Dr. Taylor, and he saw our sort of director, and it was immediate, and that's really important. Our clinic director was telling me this was a man who he went to federal prison for conspiracy. So it was a serious crime. He was with a group of other folks. He was the lookout when they were robbing a business. He was someone living with mental illness before he was involved in the justice system. When he was going through trial, his wife committed suicide. When he was incarcerated in federal prison, his cellmate attempted to commit suicide, and he saved him. He was the one that lifted him up and called the guards and saved him. And Dr. Taylor, as I was asking, she was saying, you know, he was born to a mother who was 14. I bet in one of the neighborhoods that Liz has described. And you know, his mother sort of gave him away to her sort of partner's family, and they abused him. And so it's an interesting thing when we think about who are the people. It's really complex, which means that we need really complex sort of responses to people with behavioral health needs and mental illness involved in the justice system. And so I'm going to turn it over to Dr. Taylor, who's just going to talk about a person.
Thank you. Thanks for the opportunity. So I just want to give you a snapshot of an individual that I see on a daily basis. I work, as Anne-Marie mentioned, I work with the adults, but also with the youth, and this individual is 18. I was asked to see him because he's going to school and was isolative, and the thought was he paranoid because he was mumbling to himself? This is a young man who had not had any psychiatric services, lived in a household with two parents, both who worked. There were immigrants. His dad was from Trinidad, his mom's from Guyana. He had an older brother who completed high school, was working, and an older sister who was out of the household. But he was tall for his age, and most of his power came from being on the street. And he admittedly said that, you know, he was a bully and good at it. But things changed 2 years ago when he got shot. And when he got shot, he started feeling more anxious for no reason out of the blue. He felt scared on the street, but the street was where his allies were. But then because his parents were hardworking and did not understand the street culture, inside his house, nobody wanted anything to do with him. So for 2 years, basically, he's been on his own in terms of trying to figure things out. And I can't remember exactly what his charge was, but I think it might have been jumping a turnstile or trespassing or something that got him connected to cases. So he's got the anxiety. He was self-medicating with marijuana. But since he's in cases, and as he said, since I turned my life over to cases, he could not smoke anymore, but was trying to figure things out. as it turns out, yes, he had some symptoms of anxiety and post-traumatic stress, but also the mumbling was about the fact that he felt wide open. And the reason he felt wide open was because he had just broken up with his girlfriend and he had feelings, normal feelings. And I was like, buckle up, because that's going to happen again and again. But because he was actually feeling something, he wondered if he was gay. And most of his mumblings had to do with whether he was gay or homosexual, and he had a lot of issues around that. And I said to him, just because you have feelings, like, where did you get that if you have feelings, there's something wrong with you, or you could be gay? And he said, French Montana. Now raise your hand if you know who French Montana is. French Montana is a rapper who sings a song about guys can't love no hoes. And when he said French Montana, I said, French Montana? I said, French Montana has a mother and sister. I've seen pictures. I'm sure he says he loves them. And at the time he was going out with Khloe Kardashian, I said, I know he loves her. And he just got this big sense of relief. And this was a young man who didn't need an antipsychotic. He needed psychotherapy. And I work with a wonderful social worker who's a therapist who actually had brought him to me. And so we went back and I talked about what this young man needed. But it's just an example of an individual who came from two parents. Yes, you know, he had this life on the streets, but that wasn't working for him anymore. And we were able to identify him and do psychotherapy and help him understand his feelings and how to process his feelings. Certainly to do some cognitive behavioral therapy so that he can deal with his anxiety, but he did not need medication and certainly did not need a label. He just needed to talk, and he had no one to talk to.
Great. Well, as I was listening, a couple of things have been come to mind. And one of them is that I have always, I mean, I'm not an expert on mental health or behavioral health or anything like that, but I do know that it can be incredibly expensive, and it's a very long-term process. So as I was listening to each of you and speak, I'm thinking, do we have, actually will we have that type of commitment in order to provide those type of services? I mean, you may have like a major breakthrough, but then there's so many things. It's almost like an onion. You're peeling one layer, and then there's another layer, and then there's another layer, and then there's another layer. So I guess the question for me is it realistic to think that we will be able to really put a sizable and long-lasting dent on this topic, this issue?
Oh, everybody looks at me. I'm the bureaucrat. Honey.
And I'll give you the mic.
I may want to say this softly. So I think there are a couple of things about that. One, I think it's expensive what we're doing right now. You know, jail and prison is no joke. So if you think about those 400 high flyers that I was talking about before, yes, supportive housing is expensive. You know, it's $20,000 for a slot, whatever it is. But when you think about sort of, you know, not put aside the social harm, when you just think about what the costs of hospitalization, homelessness, you know, jail and prison stays are, that's sort of one thing. I think the second thing, which is really important, is sort of what David said, which is there's a recognition now across the political spectrum, whether motivated by you know, the cost factor or by a social justice factor or by anything, that sort of a number of different things are now winding together, so that I don't think you get a lot of pushback on we need to invest in things that are going to work. And I think even in this city, just even in the last, you know, sort of 4 or 5 months, you see sort of a heightening focus on just this issue, on mental health issues. So I think, you know, there may be sticker shock, but I think that sort of people are to some degree skilled to it. And I think sort of a third thing, which goes back a little bit to what I was saying at the beginning, which is, you know, we spend plenty of money right now anyway. Forget the collateral costs. You know, we pump huge amounts of money into programming. but it's kind of all higgledy-piggledy, right? You know, sort of, there's Rockefeller drug laws, and then we have like a lot of money going into substance abuse, and then we have, a lot of money going into all kinds of things, but we've never really kind of done a rotor-rooter through and said, look, here's the profile of populations in need. Here's actually how we need to allocate, our funds, and maybe we have, too many of this kind and not enough of that kind. And I think we're getting to a point where kind of that won't stand anymore, that people care about what works and what doesn't work. And really it's sort of, I think, to a large degree, it's up to government to steel ourselves to sort of what is often the political reality of saying to providers, A through L, who have been getting money forever and ever, say, we either need services that work or we need a different kind of service or whatever. And that's, so, that may be where the complication may be.
I can add, just, I don't think the Affordable Care Act is a panacea by any means, but it is, one of the largest expansions of coverage for substance use and mental health ever in the United States. It's new financing structures for the types of programmings that have been very dependent on state grants from foundations to get programs running. There's new opportunities to think about how to kind of pool on those dollars, and all those things haven't been figured out yet, but there's conversations. So, that's a tiny piece of the puzzle, but I do think it's an important one just to think about sustainable finance for things, to pilot them, figure out if they work. We know in the short term some things are going to be more expensive, but you pay for these things either way. You just have to look at your priorities. If you look back historically, for things like substance use, people who need treatment, like 15% of them get it. Some people it's less. At the same time, the federal budget for, drug law enforcement was like 19 billion or something, like just crazy. You have to think about, terms like justice reinvestment, which has to do with like lowering corrections populations and reinvesting that money into things that prevent kind of the cycle of recidivism. I would like to see some of that money actually not go back to kind of justice world, but think about where we've shortchanged other social, public sectors in the past. So thinking about giving some to the neighborhoods that you're talking about, the other kind of things that are critical to their ecology. So reinvest in that money.
Another question I have is that what you're also describing is really almost a massive cultural change. Not necessarily with the criminal justice system, but all of the social and community service systems. They're really going to have to change, and correct me if I'm wrong, but it's almost a behavioral change on everybody who's going to be involved in every point of this process. And that, maybe that, again, I'm wrapping my brain around that just seems, again, a very enormous task. And again, is that, how do you get, the judges, the social workers, the supportive housing people, the mental health people, people who are dealing with Medicaid. There's so many different pieces of this puzzle. How do you get them to all work together and so that the outcome is the way that you've envisioned it? Or is that the next step?
Well, I'll say,
everyone keeps looking to the
No, well, I think you surround them. I think the critical thing is that no one is an island, and everybody works as an island. And that just can't stand anymore. And so today, the MacArthur Foundation announced $75 million that they're going to spend to reduce jail populations. Now, it actually doesn't have much to do with jail at all, right? In order to reduce jail populations, you have to figure out how you stop people from going in the first place, and how you stop people who come out from going back in. And yes, are there things we can do inside that will stop? Yes, but that's not where your big reductions are going to be. So something like that says, I don't want to hear from provider X or district attorney Y or judge Z when you apply for this grant to try and reduce prison populations. I want to hear, I don't know if this is what they're saying, this is what I'm thinking they might be saying. I want you to think about this systemically. And the system is hydraulic. We cannot continue to just say, okay, we're just going to look at this part, but we're just going to look at this part. We have to sort of see it as an interlacing system that doesn't interlace that well, but in order to solve it, we just, we can't sort of squeeze one part of the balloon.
And I think that it's not like we're starting today with change. I think that change has been evolving sort of over time. I would encourage us to think about the change that's slightly bolder than what we have been doing. And so when we think about people with mental illness involved in the criminal justice system, most jurisdictions and federal funding is really focused on low-level misdemeanor crimes. And how I'm now thinking about who are in the jail are the people that get stuck in the jail, that can't get out, and sort of creating those pathways, it definitely needs collaboration because maybe they're more risky. And so, but that's not necessarily new to people that are judges and prosecutors about how to take informed risk if it's something that works. When I was with Jennifer Scheme last week, she was describing how there's a lot of new focus on risk, and there's actually not a lot of evidence out there that risk-informed strategies work for people with behavioral health needs. And so she was sort of suggesting we also, in trying to get people to work together, must make sure that we're researching and actually having the evidence. Otherwise, we may be wasting money again by doing strategies that don't necessarily produce the outcomes that we're anticipating.
I have one more question, but I think I'm going to hold it because I'm looking at the clock. So is there anybody in the audience who has a question? Yes.
Yeah, I think just about the question of the readiness, like things have come together in New York City to make a moment happen. So I appreciate that a lot has been done before, and I think there have been a lot of people working on this, and there's just a moment in time now, which is really excellent. And I think that there's a lot of changes that can happen because of this moment in time. So I think that there's ripeness here to make some of those systemic changes where they might have been identified for the last 20 years, but now there's a willingness to look at it. The one thing that I think is missing a little bit, I'd be interested in hearing about this. I really do appreciate this construct that there's 400 frequent flyers and they're causing a lot of friction in the system and they're grinding the system. But that means there's also, an additional 9,600 people in jail every day. I think the question is also relative to the mental health system about prevention. And I'm a little worried that there's a lot of focus on people who are already at that tip, they're already like they've grinded the system to the point where they haven't been able to find good care. So you're providing good care to people who sort of have already had to go through the system. We need to figure out something in communities to really support a good mental health treatment, identification, treatment at a different point in time. So I guess I would like to know how you all are bringing that into this process, because if we don't do that, we're just going to keep creating the funnel, right? The pipeline is just going to grow. Maybe they'll go smaller, but it's still going to be, and we're always going to fund that sort of the reentry stuff instead of thinking about how do we turn some of that funding towards communities. So this young man that you mentioned, a really great case in point, like surely we could have found him earlier. Maybe we could have, maybe we couldn't, but we should try. So I just wonder about prevention and how you think about that relative to the work you're doing.
Can I just add, I think to your point, literally 100% of the women I see have been sexually abused, and probably 80% of the men. So if we could do something with sexual abuse and physical abuse, childhood trauma, I think that's where a lot of the money lies. And the other thing I think we don't talk about is, there's a study about first grade readiness as prevention of violence. It's not just kids knowing their ABCs, but being able to identify their feelings and the feelings of other people. And so it's softer and harder to measure, but I think if we're really serious, at the point that we know a woman who's in poverty and has a baby, we need to go in and teach parenting skills, teach them about keeping people out of their beds who abuse them and their kids, and about teaching their kids how to identify their feelings.
No, I think it's a great point. And I think that you're right that there's also this moment right now. So, again, sort of to David's point about it's kind of in the groundwater. So, a week ago or 2 weeks ago, I think I saw Jeff someplace in the group, but, there was this big announcement that the city is going to do this huge mental health roadmap right? Which is not just about the criminal justice involved, it's about sort of how we deal with exactly the issues that you're talking about. And then whether separately or apart, but you know, they are clearly connected, you know, the Department of Health is going to open a bunch of community health centers that I think, you know, sort of the whole point is at least you begin to have the infrastructure to deal with some of the issues that, you know, you're talking about. But I think actually having a strategy and figuring out, okay, are we going to do that with first grade readiness with everybody? How are, you know, what is the strategy that we're going to do about, you know, sexual and physical abuse? You know, hopefully something like the roadmap is a way to begin to think about it, you know, systemically.
And then Joel.
So thank you all for your comments. I'm Al Cohol. I'm at the School of Public Health at Columbia. I'm a physician, and I just want to complicate the issue a little bit. I take care of young people living with HIV, and thinking about the overlay between substance use, mental illness, incarceration, HIV, it's all there. There is somewhat of a system in place if a young person is incarcerated, they get screened, if they're positive, they get treated, and there are some linkages in place for aftercare. If that young person tests negative, nothing really happens. And so we're missing opportunities for intervention and further services and prevention for this cohort of young people. So I think as we are thinking about where to intervene and how to find young people, they're there. We have programs throughout the city that take care of young people in a coordinated, integrated fashion. We need more resources, but we're not getting those kinds of young people except anecdotally or by accident. When we do get them, particularly those who are HIV positive, we do a fabulous job with them. We suppress their viral loads and so on and so forth. So we are helping to address Cuomo's end of the epidemic initiative, but we can do a lot more. So, you know, as we're talking about task force and plans and so on, I really want to get involved with that kind of initiative as well.
So, you know, it's great hearing all of this. One of the things that comes up for me is just when you're talking about increasing the way that, or enhancing the way individuals look at other people, so that when they do have these different interactions, maybe police or teachers or social workers or therapists or providers, they see people with a compassionate view, a more open view, on a human kind of perspective. And doing place-based work and like neighborhood-based work, and thinking about how many resources are being funneled into like East Harlem and South Bronx and stuff like that, one of the things that we've been thinking about is how to reinvigorate the experience of community and reinvigorate the way that individuals see their neighbors and how you know, youth are seen. You know, I've done a lot of work in the past with youth, and one of the things that I did to support youth with the after-school program was to meet with youth regularly, just to talk about like, how's life. And you know, you're attempting to be mobile in your community and move from maybe one socioeconomic status to another, just from going into, you know, college, and what are the different stressors around that. And I'm a social worker, and so some of the things that come up too is just around people not seeing other people at all, and that whole invisible man issue, that whole invisibility. And so I think putting some efforts into just enhancing the way people experience their neighborhoods and experience the businesses that are there, their streets, the visibility, those kinds of things support the reduction of stress, support the reduction of anxiety and isolation. And so I think it could be another way to have that soft kind of like approach to reducing the populations that we have right now in jails.
So I don't want to suck all the oxygen, but I just
absolutely.
just want to.
Absolutely.
So I think you've touched on such a key point. So you know, not every poor neighborhood is a high crime neighborhood. Not every, and so what's the difference between neighborhoods that work and neighborhoods that don't work, right? And it's really all about neighborhood cohesion. Are neighbors looking out for neighbors? Are they, you know, engaged together? You know, or your grandmother's looking out the window, or you know, all of that stuff. And that is absolutely at the heart of this sort of 15 neighborhood effort that we're starting now is how do you quite intentionally build, you know, as it's fancily called, collective efficacy, right, but neighborhood cohesion, and how do you do that in a very intentional way? And then sort of as a piece of that, how do you think about the built environment, right, as affecting behavior? You know, if the lobby of a housing development looks like a fortress, it feels different than if you blow out the lobby so that, you know, seniors can play cards and look up and down the street and see everybody who's coming in. You know, if you have trees and, you know, instead of, you know, sodium lights, you know, it has not just a different feel, but creates a different kind of behavior and interaction. And so I think there are a whole array of things, sort of a layered approach, that can help build relationships, can help sort of change the physical environment, and that, yes, programming is a piece of it, but it's quite a web.
So, Liz, I did want to ask you. You made reference earlier about how all these actors are there and how we don't play together all that well. But we know each other, right? And we know each other pretty well after sort of playing all these years together not so well. But going to what David referenced before, we're about to introduce some giant new actors into this. That's the managed care organizations, the hospital, this whole new scheme, which we don't know. They don't know us. We don't know them. They, you know, you listen to the guys from the state, and then, you know, they're all in, they need us. Organizations like cases, we're like totally intimidated by them because they
no idea what they're talking about. Disrupt and heart.
Exactly.
You know, oh my God.
They talk in billions. We talk in millions. You know, it is. And so I'm just wondering, as you're thinking about this, sort of what are you thinking about? I'm happy to join the conversation about making those connections, making those, and we have friends in the room who do this, but where's this all for you around those?
As far as the Affordable Care Act and health
and
homes
these
and all
two
that.
giant things, managed care, hospitals, health homes, I mean, these giants are now in our sandbox.
Yep. So, I mean, I would say two things, and then I will have exhausted my entire knowledge on this, but, and this is something that Trish is working very hard on with all these different players in the task force. But I think it is enormous and a game changer, and I think it's actually a game changer in many more ways than just simply signing people up, which is a big thing, signing people up to Medicaid. So I think that there's an opportunity for the state, and I may have bored you with this before and drawn a picture, which is sort of my comic book way of understanding this, but you know, we invest millions and millions of dollars in services, but what works and what doesn't. We have some idea what works and what doesn't. And who are the biggest funders of these? Well, definitely localities, but also the state as well. And so there's an opportunity for the state, and I think the state is doing a lot of smart thinking about it, but it's such a fearsomely complicated system, there's an opportunity for them through the health homes to actually kind of realign the kinds of services that they are willing to fund and that the health homes would contract with, whether it's supportive housing or maybe soon, you know, vocational help or, you know, certainly substance abuse and mental health and stuff, so that we have kind of a more organized way of matching, you know, those with dual disorders to the right kinds of services that work, and so that we direct the funding streams to what does work. And I will draw you a picture afterwards. It's on my head here. But I think sort of there are sort of two important things that would make it go, and how do you sort of integrate these two players. One is it has to be systemic. Right now we're spending so much time as we have to sort of figuring out how it's all going to be built. And, you know, the more work, you know, and that's good. But at a certain point, it has to go, and it has to work, right? So that's one thing. The second thing, I think, and this may be sort of totally simple-minded, I'm sure it is, but I think it applies to this, and it applies generally, certainly, to sort of our world, you know, sort of criminal justice and, you know, the intersection of criminal justice and health. You have to have goals. And they have to be real goals. So, you know, the writers' population has dropped by half in the last 15 years. We pretty steadily, both on the state level and on the local level, at least in New York City, drop about 1 or 2% a year. Actually, in Rikers, it's even more than that. You know, we dropped about 12% between last year and this year as far as population goes. And that's kind of without really trying, right? So I think we need to be able to say, look, in 5 years, we're going to drop the population. I'm just using this as an example because I think you can set different goals. But you have to set a goal that will drive lots of activity. If you say, in 5 years, I want Rikers to go from 10,000, which is what it was this morning, to 5,000, that requires us to assign people up to Medicaid, to ensure that we intervene in frequent flyers, to make sure that we have is it called primary preventive care? I always mix up the primary, secondaries, tertiary, yeah, but stopping them before they, it means you have to do all those things, and you have to do it in a coordinated way. So I think sort of those two things, making sure the system actually is a system, and then setting goals for that system are critical. And what we'll do in our own little corner, and are doing right now, is to make sure that in sort of the work of the task force, which tries to see everything across the entire spectrum, to make sure that, you know, what's happening at the state level, what's happening in the Brad H, you know, litigation, what's happening coheres so that we are ensuring that we're connecting people to, you know, the right kinds of services.
We have time for one more.
Hi, good afternoon. Nora Rasig. I'm the Director of Family Services at the Housing Authority at NYCHA.
Oh,
and I would love to make those lobbies, you know, places like you've described.
Let's talk afterwards.
And you know, there are a lot of layers to this onion. The one layer that I'd like to add, which I think, you know, is a key one, and your case study sort of exemplified that, and that's the family involvement. At NYCHA with Vera and with Corporation for Supportive Housing and a bunch of other reentry providers, we launched a Reentry Pilot a little over a year ago to allow people who are coming out of incarceration to move in with family. It's a family reunification model who live in public housing. Now, many of you probably know that most people with criminal backgrounds are not allowed to live in public housing for sometimes very long periods of time. So, you know, it's a very innovative pilot in that we're allowing people with criminal backgrounds to come right in and live with family. But, you know, one of the things that we discovered in the year or so, and we hope that the pilot is going to be scaled up and won't be a pilot anymore, that's our goal. But one of the things that we discovered is that people who are coming out of incarceration, and yes, a lot of them do have mental health and substance abuse. Actually, we see more substance abuse than mental health, the referrals that we're getting. They've burned a lot of bridges with the family. But most families are willing, if they come in with the right services, and not just support services for the individual who's coming out of incarceration, but support for the family. And you know, the feedback that we got, and the model for this pilot is that we provide not just services through the reentry provider to the individual, but that we provide support services to the family. Is with the right support for the family, a lot of families who might otherwise turn that person away do want them to come back home. So, you know, I think that part of that sort of interlacing and, you know, bringing all the systems together, the family really does need to be, and I was on the behavioral task force 100 days.
How was your experience?
It was great. You know, I've never had better brainstorming sessions in all my 25 years in the city government. But one of the things, and one of the recommendations on the group that I was on that we made, and of course no good deed goes unpunished, so I was given the task of preparing the working paper around it, was, you know, building in the family support component. So, you know, I just sort of want to add that to all of those different pieces that we're looking at.
Great. Well, I can kind of, when I first walked in, I kind of had a feeling more of a glass that was half empty. But now at the end of this, I'm starting to feel that the glass is half full. So I want to just say thank you again to our panelists. I think it was fantastic. I hope everybody was able to learn something new. something to take away from this. Sounds like there's also opportunities to make connections and further the work, so please take advantage of that, and thanks again.
Thank you.